Hi.
Ugh, why do y'all keep coming in my room? Like, God.
You've had to see so many people.
And I'm tired of it. Like, I already know I gotta get my legs cut off. Like, that's what they keep saying. Like, I don't have a choice.
You don't feel like you have a choice in this.
I know I don't. The doctor already told me that I don't. If I don't get him cut off, he's like, I'm gonna die. It's gonna be worse. It's gonna spread. Like, I've already heard that a million times. So you don't need to tell me anymore.
You've had to see so many people since you've been here. And my experience of working with a lot of patients here in this hospital is that we do a lot of things that piss people off. Can you just tell me, what are the things that I can do to avoid making you feel unsafe here, or making you feel like we're just getting up in your space?
I don't even care about that. It's just that, like, my mom hadn't come to see me. Like, nobody even knows what's going on because everybody's like getting high, and I want to go outside and smoke, and it's just a lot. And they want me to get on Suboxone or methadone, and then they want to cut off my fucking legs. And now they're trying to tell me I can't take pain meds, oxys. Like, what the fuck? How you gonna cut off both my legs and then not give me no pain medicine? Like that doesn't even make sense.
So on top of all of this new stuff that happened to you and everything you're dealing with in your life,
and nobody's listening. They're just like, it's bad enough I got it. Like, what if it was you having to get both your legs cut off and then you can't have no pain medicine? Like, that don't even make sense.
You feel like they're judging you for wanting pain medicine.
Because I'm a dope fiend, because I shoot drugs or whatever, you're gonna cut my legs off and just let me suffer? Like treat me like a dog.
So you're being judged for not just wanting pain medicines, but you're being judged for having disease.
Yeah, like everybody has an opinion, but nobody knows my life. They don't know what I've been through.
What can I do? What can I do to not make the same mistakes?
I don't know. It's just a lot having to deal with this, you know? Like, imagine if it was you having to get your legs cut off, like how hard that would be.
I can't even imagine. And I don't have to deal with all the other shit that you have to deal with.
Yeah.
You know?
I'm just trying to, I don't know. I'm just mad, you know? I really would like to go out and smoke. I really want to go out and smoke a cigarette and just, I wish my mom would come. Like, I don't want to go through this by myself.
Yeah, you don't want to be alone.
I mean, I know I got to do it, but I don't want to go through this by myself.
So you feel like no one has your back on the medical team, and then not only that, your family's not there for you, and you don't want to be alone.
I feel like they kind of have my back, but they don't really, like, you know what I'm saying, care to listen or like know what's going on. You know what I'm saying? Like, they're more or less judging me. They're not giving me an opportunity to like be a part of the decision. Like, I want to be heard. Even if I'm wrong, at least meet me halfway, you know?
Yeah, you want us to treat you. You want us to treat you like a real adult.
Right.
And you've been through some things that we can't even possibly imagine.
And I know how much dope I smoke. I know how much dope I shot up, how much dope I smoke. I know how much I need. I don't need to be on these low doses. Like, I know how much my body can take.
Right. Yeah, you don't feel like you don't feel like we're treating you like someone who knows anything about this.
Right. And I'm tired of them coming in like saying one thing and then the nurse will come and say, this is what's in the chart.
Feels like we're not all on the same page with all this.
It feels like I'm being lied to.
So you don't feel like we have your back. You don't have anyone who has your back from your family. Can we be that? Can we at least try?
Oh, well, I'm willing to try with you. I don't know about everybody else, but I'm willing to try with you.
Okay. Well, I'm gonna pause out. I'm gonna step out for a bit.
Okay.
Is it right if I come back later? And
yeah.
Maybe we can talk more about what.
And can you talk to my doctor about my oxy and my Suboxone and how I'm gonna do that?
You need to get some better pain control.
Yeah, please.
You need better pain control.
And some psych meds.
Yeah.
something for my
You
anxiety.
need something to help you feel safe.
Please.
Here. Yeah.
Please, can you do that?
Yeah, we can do that.
All right,
Okay.
thank you.
Okay, so this is Lori, and there are some things that I observed here that were, I think, part of what you're trying to show. One thing was the positioning. I noticed Andy immediately got lower. Dr. Seaman was lower, wasn't standing over Onisha. That was one thing I observed. And another thing that I noticed is that Dr. Seaman made a point of saying, you've seen a lot of people, and my experience is we do a lot of things that piss you off, and what could we do better? So it's sort of like acknowledging that people in medicine sometimes might not say the right thing, and then asking what would make it better in order to better meet her needs. I think what I observed overall was just, Andy, you were mirroring a lot of what Onisha was saying. So it seemed in that way you were validating her.
Right. Yeah, thank you. And so typically when we do these reflections now, we'll talk about this a little bit more. Thank you for that, Lori. We'll start with the provider, because as you know, in the modeling scenario, it's not that important. It probably would do exactly that. When they do their skills practice, the person in the hot seat is the provider. It's hard. It's hard to be watched by your peers, you know, practicing this new skill set. And so we'd start by reflecting ourselves on how we feel, and then we'd ask our patient how it felt. And so at how I felt, you know, I think at first I was a little bit lost, and I had to find my footing, but it did come. You know, I think that she was just struggling, you know, and she just wants to be heard. She just wants to be heard. And so what I was trying to do is, so with environment, there was a chair blocking her exit. I moved the chair out of the way. I got down. It was a little hard because of our space issues, and I'm sorry if I fell off the camera, but I'm gonna usually I'm gonna have a clear path to the door too, but I'm gonna ideally get, you know, make sure she has a very open path. I'm gonna get below her. When I look at her, I'm gonna look at her directly, but I'm gonna change my body so that it's about 45 degrees to her stance, because facing your body directly at people is an aggressive stance that people intrinsically coil back from. I tried to reflect not just what she was saying, but I tried to interpret a little bit and try to find the things she needed. So what I learned was that she feels completely alone. She doesn't feel like she has autonomy, like she can go out and smoke cigarettes. We didn't get enough time to really work on all of those things. She doesn't feel like she's valid as a human or respected as a human. And so I tried to, by reflecting those back, and sometimes you'll reflect back and they will respond to you and you're wrong, and they'll correct you, and that's okay. But it's much better than asking a question. So downward inflection says that I hear you. Upward inflection is like, I don't know. Is that what you're saying? Is that real? And so try to model that the best you can. And then reflecting values. So her values, oh gosh. Well, let me ask you, how did it feel? How did it feel to you, Anisha?
So a couple things. I really like the way that he rolled with the punches because when you first go see a patient, they've been getting fluffy mess all day. You got to remember the nurses are coming in every hour, and the fluffy, how are you doing? Do you need anything? But nobody's really taking the time. She was complaining, which is what you'll get a lot. And what I've seen in reality, in real life, is a lot of the doctors can be very defensive. When you're talking about this hospital, this doctor, these nurses, this procedure, I'm not getting complaints. And the doctors will be like, well, you know, they'll start defending. But he didn't do that. He reflected he didn't agree. He didn't say it was law or that it was fact. He just was saying, okay, so this is what you're saying. Like, I felt very understood. It helped me open it up a little bit to see, okay, maybe this guy is an ally. He's really listening to me. Let me get to the nitty gritty. Can you talk to them about my medication? Because seriously, like that's where she was going. Like, am I be safe to have this procedure? And are you guys gonna treat my pain? Or are you gonna make me suffer because I'm an addict? That was her that was her biggest concern that he could fix, that he could be a part of. And I think she felt safer in the end to ask him that because he seemed like he was really engaged and willing to listen to her. Because you can't reflect unless you're actually listening. So I think that that's good, and not getting upset because she had an attitude, wasn't making contact, and like I said, complaining, didn't take a defensive mode to defend the hospital. Well, that, you know, he just rolled with the punches, and really she felt listened to.
Thanks. Let's bring up the PowerPoint again. Great, thank you. So we had a timekeeper. We were also keeping track of our time on our own. And then typically that was the same amount of time we had to reflect than that we used for the role play. Generally, you're gonna want about double. So for your actual skills practice session. There's a lot more to talk about with this. We could talk about that for 10 or 15 more minutes, but I think we'll pause here. We can get questions later. We'll try to do this again too. Next slide, please. So again, as we sort of mentioned, so when you start structuring your skills practice, which we're not going to get into quite yet, you're going to start with your clinician, okay? So this will be you. So in the modeling exercise, you as the facilitator will be the first clinician anyway, and your learner will be the clinician in the skills practice session. We'll talk more about that. Then start with the patient. So again, and if you can, we're trying to reflect back our experience of it. I didn't actually model that very well, but trying to reflect back, how did it feel when I was talking with the patient? So I felt like I was hitting a wall when I did this specific thing, and then, you know, we said this other thing, and then it seemed like things were moving. So people can sort of process in real time, what are the words they use, what are the mannerisms they used, et cetera, that worked and what didn't.
Do you remember what that was before I felt comfortable enough to make that eye contact with you and engage?
I don't. Do you remember?
No. But I know it was something. We need to pay attention to.
Yeah, and it's hard, and that's why we have observers.
Yeah, they can tell us.
And so the next time, so sometimes your patient will feel that way, and I think especially when people are new at this and maybe they use word choices that aren't ideal, or sort of ask questions. We're driven to ask questions, so don't stop asking so many questions. You know, when they maybe ask a question, usually that's when the conversation stops. And it'll be a lot easier for the patient to say, you know what, when you asked me that, I just didn't want to answer.
Yeah.
So you get the idea though. And then with the observers, ask your observers to be as specific as possible and write down quotes if possible. So next slide, please. Okay, so this has been a lot in your session. So they are going to need to have some time to blow off steam because they're going to come back and do some skills practice. And that's, again, it's really, really hard for them. So let them, and if it runs over a couple of minutes, read the room, let it run over a couple of minutes, and that's okay. But let them blow off some steam, run around, go to the bathroom, whatnot. And I would shoot to have that first session to be under an hour, if possible, maybe 50 minutes with a 10-minute break if you have a 2-hour learning session, and then to leave a full hour to do skills practice. Next slide. And now set your skills practice background. So they're all going to come back. Hopefully they're feeling a little bit better. And now they've been laughing and doing the things that they do after you feel a lot of stress. And then now we have to be really explicit about this. No laughing. I know this is hard. We're going to do skills practice, not role playing. We're going to do skills practice. I know this is hard, but we all need to do this together, remembering and respecting the people in the room who have experienced trauma, remembering and respecting the patients you've had who've not done well because we have not done service to them in this. So this is a really important skill set. To establish the reasonable group sizes. So, you know, you can do your didactic-ish in a modeling portion with a bigger group, but if you can, no more than 7 people, and 3 to 5 people is a better number. 3, give each participant a job. So if you have a job, you're less likely to kind of wander off. So 1 patient at a time, 1 to 3 providers. I can talk to you how to do that. 1 to 3 observers. And again, if you have 3 observers, give each observer 1 specific thing to focus on, or you can ask them, what specific thing do you want to focus on? Remind them to use quotes. and a timekeeper to keep you on track. And that timekeeper should have the authority to move things along and just say, great, go, and so on. That could be the facilitator, it could be someone else. Give someone a physical handout of cases. So they should have a case in front of them, which obviously we didn't do for you very well, but you should have your case right in front of you. They should be looking at the case, or they can be thinking, well, what would I say in this scenario? And then you should tell them what specific skills they should be focusing on for the case. So as your learner or your provider practice these skills, they should at least be trying to do 2 or 3 of them, not all 7 of them or whatever. And then max 1 facilitator for 2 groups if there are small groups. And ideally, there's 1 per group, but there are scenarios where you can set up 2 small groups next to each other and then sort of roll over between the 2 groups and listen to what they have to say, so you can pick up some specific feedback for them. In an ideal world, all learners get to practice being a provider at least once. And I don't think I specifically talk about this later. One way you can do this, you can set up something called a fishbowl, which is where instead of just having 1 patient and 1 provider at a time, you have 1 patient and sort of 2 providers teed up, 2 or even 3 providers teed up with a couple observers, and you'll have your timekeeper move along without break for reflection, move along the provider to the next provider to the next provider. So if you don't have much time or you have too many people, that's one way you can do this quickly. If you do that, you need to have plenty of time for reflection though. Next slide, please. So again, this takes time. I mean, if you can do more than an hour, that's great, although I don't think most of us can stomach that. I think we'd all get a little bit burnt out on it. Facilitator's job is to move the discussion along, to keep people on time, and to provide feedback last. So this is ideally the learner's job. Ideally, the learner is providing most of the feedback, because that's also part of the learning exercise. And then one example session might be 1 longitudinal case or 4 short cases. So we developed 3 separate cases with that we thought exemplified different components of trauma-informed care, and then 5 minutes of skills practice with 5 to 10 minutes of processing time each. Next slide, please. So, and learners should focus on observations rather than advice. So clinicians should observe how it felt, what they struggled with, and what they did well. The patient should observe how it felt to receive this care. Okay, so if you can, try to keep people from giving too much advice at the beginning, although it's going to be inevitable. But how did it feel? How did it feel when you did this? Because you'd be surprised, even the most ardent rejecter of role playing will feel something when their provider is coming at them. So try to get them to tap into that. And then observers should, again, write down quotes. It's so much more powerful if you have the quote than if you have a generalization. And then make sure that quote is demonstrating a specific skill or principle. And then again, we talked about the facilitator role. Next slide, please. So I think we are.
I had time to do that.
Is it 2:47? So I think that in order to, well, let me take a pause. Lori, do you have a preference as to whether we move into a couple questions now, or if we do one more quick role playing of an exercise that demonstrates a grounding exercise?
I think it's fine to do another role play.
Okay, so we'll be really quick. If you could switch us over to the camera again. And do I need to do the share screen?
You're good.
Okay, all right, good. So
I didn't get to read it.
just gonna do, so we're gonna come back into the room and you are going to be triggered, yeah.
Okay.
And basically, you want to leave the hospital, but you've done, so at this point, just to set it up for everyone, so Shauna is, she has been doing a lot of great work. She's been induced on methadone. She's been getting more pain control, and has really made some real progress, and has been thinking about going through with the procedure, but someone, a new provider came in, or I think the surgeon came into the room and said something that just really, really triggered her about her pain medications. And so we have a pre-existing relationship coming into this, okay? And keep this really short, okay?
Mm-hmm. Yeah. Am I good? You have to come in some more.
Okay.
Yeah. I'm so freaking pissed. Like, oh my God. Like, so this new doctor, I guess my regular doctor went on vacation or whatever, and like they freaking like are trying to take my oxys off, titrated, something that they gonna take me off. And like my methadone is at 60 because I know he already know, like you already know I have to get my surgery done. So everything was already set up. And I don't even know where the fuck he even came from. Like, who is he? And I'm pissed off because my mom finally came and she took my debit card and fucking spent all my money. And like, I'm just ready to fucking go. Like, this is fucking stupid.
Can I just say really quickly, Shauna, like you have made
Oh my God.
so much progress since you've been here. I mean, is it okay if we just take a step back for just a second? Is that all right? And
I'm just like, oh, though.
yeah. So what I see,
I was doing good
Yeah,
until he came,
exactly.
though.
Exactly. So you were doing so good. You had, when you came in, you were just in withdrawals. You were feeling terrible. You were just like, this was not a good thing.
And like, I'm feeling a lot better, and I appreciate y'all for working with me. But now I got a fucking new doctor that's like trying to switch everything up when I'm finally fucking comfortable.
So you've done so much work. Is it all right? Can we try something? Can we just try an exercise real quick? Would you be willing to do that?
Oh, Dr. Seaman, what do you want me to try? I'm so mad right now. What is it?
So something that I found helps sometimes when, someone comes in, sets you off for good reason, for good reason. You didn't feel respected. Maybe you weren't respected. I wasn't there. Sometimes it helps to come back into the room and can you just tell me 3 things you see in the room right now?
A board, a cabinet, a door,
What are 3 things that you hear in this room right now?
the air blowing, people talking in the hallway, and my voice.
What are 3 things you feel in your body right now?
The air blowing on my skin, my hands, and lotion I just put on.
Do you mind just humor me? And I know this is annoying, but just take one deep breath. Just... Do you feel any different?
I guess. I'm not as pissed off as I was. I mean, I'm still mad, but
I want to be clear. I'm not saying any of this is your fault.
yeah.
I'm just saying sometimes when we get worked up, sometimes it just helps to take a break for a second and think about the big picture of how many amazing things you've done in the last 2 weeks and how much closer we are to getting you the things that you need. You have, most of our team has backing. And I know your family's not coming along, but it's not going to be fixed overnight.
Yeah.
So we're closer. Let's hold on, okay? Is that all right?
Yeah.
Okay.
Yeah.
So sorry, so let's break it off. So it's different every single time. And I think grounding exercises can be extremely useful if you have some relationship. I would not roll into a room and say, all right, breathe with me.
Right.
Like that's likely to not go well.
We had to have built a relationship before.
Right.
So he's been in to see me like maybe 5, 6 times. Something.
Yeah. And I think that if you didn't have that to reflect back to, it wouldn't be useful. We didn't have a chance to practice this one. I think one of the things you'll notice when people are triggered is their entire body language changes. I mean, generally speaking, there are a lot of different ways. It's often either an aggression pathway, like acting out, because if I act out, what are you going to do? You're going to back up. And what I'm trying to tell you is back up right now. Or people retreat and they get very fetal and their eyes go down. And when you see either of those things, you know the person is no longer in the room with you right now. And so the purpose of a grounding exercise is to bring them back into the room. It can work, it cannot. I would say it's only backfired on me a handful of times, and many more times it's worked, but I also don't use it that often. I use it when it feels like it can be useful. I don't know that I did a great example of that, but I think that you get the idea.
Yeah.
I have seen people unfurl, like they are completely gone and they completely come back. So it's just one more thing you can do. I'm going to pause there, and I think.
And I want to say one
Oh,
quick
I'm
thing.
so sorry,
As a
yeah.
participant, just that it feels very good that my language, as you notice, is fuck this, fuck that, no reaction, receiving it, receptive to what I have to say, and not defensive of hospital. As sometimes that's important, but not in this moment. Just receiving what I had to say and helping me switch to a different frame of mind very smoothly. And I love that. No reaction to the cursing and the anger, and not defensive at all to the things that I'm saying, even about his fellow doctors, just reflecting and moving me to a different space.
Thank you. All right, so let's take questions. This is
We got 5 minutes, 6 minutes.
This is truly too much to fit into an hour, but
Yeah.
I hope that you get the concept. You're welcome to use our slides. We also provided with our toolkit, which has the core principles and then the core skill sets that we've developed. That we print off and put on a little laminated card. They fit in your pocket. I will say that quickly, we have not evaluated this yet in our program. It's just one of the thousands of things on our to-do list that hasn't been done yet. And so it needs to be to examine whether it has a meaningful effect on quality of life. I would say that the residents I've worked with who have been practicing this have told me that it's really helped them. So just with that, we'll stop and we'll take some questions, and I'm happy to stay over, a few minutes if we need to, till about 11:10 or so.
Yeah, that's fine.
To answer questions.
Well, I wanted to thank you so much, both of you. Those were great role plays. And I just wanted to ask Dr. Seaman, you said that there have only been a handful of times when you tried that grounding exercise and it didn't work. What signals did you not see in those instances? Do you recall?
I think I didn't have the relationship yet. It was just that we didn't have enough, they didn't have enough intrinsic knowledge of me.
Mm-hmm.
It was, in a teaching setting where I came in and did a brief intervention when the resident had been in the room with someone for a while.
Mm-hmm.
And I just didn't give it enough time. I would say that's the biggest thing. I think if you have buy-in, one of the things that I've noticed is some people, not all people, but some people with early trauma are because they've learned that they need to defend themselves from a very early age. There's a tendency to be a little more binary. You're either on my team or you are not on my
Right.
team. If you're not on my team, a grounding exercise isn't going to do anything.
Mm-hmm.
And I'd like to ask Onisha if you could talk a little bit about what are the ways in which you think that clinicians can build trust and also teach this to students. Like, how do you show that? What are some other examples?
Well, the biggest way for a clinician to build trust, I feel like, is to, first of all, talk to them as a normal person, know that they have a significant amount of intelligence and strength, and don't be too offended by the aggressiveness or the pullback or the stoic. Some of our patients can be very stoic. Just roll with it a little bit and understand that you have to earn that trust. You have to come in day after day, and you have to be willing to give it time. Some people are going to be a hard nut to crack. They've been through a lot. They've been lied to. They've been told one thing, and I know that it's not lying. What it is the physician has made one note, and then somebody overrode it, and then that physician is busy somewhere else, and they can't come back to the patient and explain to them why the plan that the patient and the physician made is not currently being put into play because changes were made along the way, and the patient doesn't know that. So they feel like the physician has lied to them. So that's another way. Like, take the time, have a layman term conversation with them, but explain to them what's going on and why. Explain to them what they can't do. Don't make them promises that could be override by their primary care team, because we're an addiction team. So things can be overridden by the primary care team. And when things change in their protocol, come back and explain to them why. Like the deserves, I know you get busy. If you have to page the nurse on duty and have that nurse deliver a message, those are good ways to build relationship, communication time, and believe them. When they tell you something, believe them. Like don't try to talk them out of not being in pain. If they say they're in pain, believe that they are in pain.
Okay, thank you. And I also wonder if you can give examples of how in a setting when you're actually working with the medical residents, like how does it work? How are you coaching students when you're interacting with them during the role play?
So my experience was, I think we split them in half. So I had like what, 15 residents, was it? About 15?
Which was too many.
Yeah. And so, they surrounded me and, I talked to them. I told them a little bit about my personal story. And then I went into, a skill practice exercise and, they tagged out. And because this was a learning experience, I pulled up the hardest case and mixed it in with a little bit of my own personal stuff. And I just created this impossible person. And I just went at them and they came at me one by one. And when they were hitting a roadblock, they said, I tag out. So I just want to say there was a lot of tagging out. And then after everybody went, then we stopped and we talked about it. And they asked me, so what should I have said here? Because I didn't know what to do. And what should I say? And then they even talked about how they felt. Like they was like, wow, that is so hard. Like it's hard to sit with when a woman tells me that happened to her. Or, I'm so angry because I want to be, I know what she's telling me is true and I want to do something about it, but that's not my role, So it's very interesting. And I think they got a lot out of it.
Oh, yeah.
I'm going to interject right now because I see we're running out of time. So there are a couple things that I wanted to bring up, which is we are going to be sending everybody who joined a link. This webinar will be archived on ACES Connection. We also encourage you to join ACES Connection, and you'll find a lot more ways to connect with other people who are interested in this issue. Somebody also wrote in, there's a particular article which we could also send you that's related to this by Diana Wagenhall on our site entitled Handled by Trauma, Childhood and Medical. It scrolled up. And I also did a story which we can also send a link to, which was with Onisha and Cochran and Dr. Seaman about this very issue. So we will make sure to send that as well. And I want to thank Onisha Cochran and Dr. Andrew Seaman for providing this training, and thank you all for joining.
Can we end, Lori, with one last sentence? One thing we want to leave people with?
Sure.
So I would like to end with, just remember that, try to remember you are collaborators with the patient. You are an expert in your medical profession, but they are an expert in their body. You are a collaboration with them. Share with them your experience, your thoughts, and I hope that you can respect them enough to come to an agreement as a collaborator and not just as somebody suggesting to them that this is what they need to do.
Thank you. And I don't want to follow that, but I would just say that your patients and our residents' patients and our medical students' patients are going to be your greatest educators. And if you can do one thing and you can convince them of that they need to pay attention to what happens when they talk with their patients and their patients aren't doing well. Stop framing it as a difficult patient or difficult encounter and start framing it as, what am I doing wrong that's keeping this from working? Because we can care for everyone and we can have really meaningful conversations with everyone. And if you can just convey that one thing, that you've sent them on their way, and all the rest of it is just, specifics and tools and whatnot.
Okay.
Thank you.
Thank you.
Thank you very much.